It's a pleasure to introduce Professor Nancy Becker, who is an associate professor and chair of the Tuft University Department of Occupational Therapy. So her clinical and research career has focused mainly on preventing and treating chronic pain. And she has over 100 publications and more than 200 presentations. And Professor Becker has helped shape the national strategies for treating musculoskeletal disorders. And she's chaired the US-born and joint initiative educational program, experts in arthritis program. And she's also helped develop national guidelines around the treatment of chronic pain with the American College of Rheumatology and the American College of Occupational and Environmental Medicine. So a couple of years ago, I think 6 years, she learned about the use of virtual reality for pain and has since been working on this really exciting technology. And we have another part of the team who's going to be giving the presentation. It's also a pleasure to welcome Dr. Augusta Hixon Polhemus. And she's an occupational therapist with experience dealing with children and adults with a variety of health and wellness concerns. And she has worked in early intervention, outpatient, pediatric settings, and she currently she's consulting for Boston Children's Hospital in their development of an early intervention application. And she also manages a research lab that studies virtual reality and pain. And her doctoral work actually examined the effectiveness of mindfulness-based programming for children who have experienced trauma related to poverty, domestic violence, food, water scarcity, and neglect in rural Kenya. She also continues that collaboration and is working with Kenyan teachers to develop teacher trainings and implement the programming developed in her doctorate. Dr. Michael Grant.
Sure. And I would like to welcome Dr. Kenney, who works in the Department of Occupational Therapy at the University of Pittsburgh as an adjunct instructor. She is currently a UPMC. She currently works at UPMC Centers for Rehab Services as a chronic pain program director. She has graduated from University of Pittsburgh in the School of Health and Rehab Science in the Occupational Therapy program and has continued there. She specializes in chronic pain management and has done so for many years. Since she's been there, she has developed multiple educational courses, a comprehensive occupational therapy pain program. She has published several papers on chronic pain and received many awards in her field. She's also active in pain research and acted as a lead therapist and principal investigator on several studies related to chronic pain condition.
Sure. Thank you very much. It's all yours, Nancy.
Great. Thank you very much. And thank you to Hixon and Michael for inviting me to speak at your seminar series in the Department of Experimental Surgery and Injury Repair and Recovery program. I'm going to share my screen. So hopefully you can all see this. And my talk is titled Into the Metaverse, Virtual Reality Advances to Treat Pain. And in this talk today, I hope to provide you with an overview. I'm having trouble changing my slide here, so I don't know quite what's going on. There we go. I hope to provide you with an overview of some of the ideas and advances and clinical applications of virtual reality for treating chronic pain. This is a virtual reality for pain is a relatively new area and a very exciting area. And I hope to provide you with some background and some ideas about how virtual reality might be used in your clinic to treat pain, or just give you an idea of some of the places that we're going with virtual reality in the treatment of pain. So today I'm going to talk about 4 areas. I'm going to talk about why we might want to use virtual reality for pain. I'm going to give you a little overview about what virtual reality is and what it's not, because my experience is that many people have not seen virtual reality in action. I am going to talk a little bit about some of the proposed mechanisms on how virtual reality might work on pain. And then I'm going to talk a little bit about how we've applied virtual reality in the clinic. After I speak, Augusta Polhemus will be talking a bit about one of the mechanisms for virtual reality, embodiment. And Kenney will be talking a bit more about how she's been incorporating virtual reality into her clinical practice, a little more depth than that. So we hope to give you some ideas and thoughts and some interest in this brand new area for treating pain. So the first question would be, why do we want to use virtual reality for pain? And you'll notice I have VRX. That's one of the new things that seems to be coming out in the therapeutic use of virtual reality, is they're calling it virtual reality treatment with an X. So that is opposed to using virtual reality for gaming or using virtual reality for education. Recently, I and my colleagues did a scoping review looking at the use of virtual reality in the treatment of both acute and chronic pain, because I was very interested in sort of looking at whether this was effective and how people were using it. I actually anticipated that we wouldn't find very many articles, and I limited it to the last approximately 10 years of time because I thought, VR hasn't been around that long. So I was kind of surprised to discover that after we'd searched the PubMed, Web of Science, PsychoInfo, and CINAHL using the dates of 2010 to 2020, with an inclusion criteria that it had to be a peer-reviewed journal and that it had to be any type of people, adults or children with pain, and excluding healthy subjects, so subjects who did not have pain caused by a disease or by an injury, but had pain that was caused in a laboratory. They were excluded. And at least one primary outcome measuring pain. I was rather surprised to discover that there were actually 70 studies that looked at using virtual reality for treating pain, both chronic and acute. Most of the studies looked at acute pain with 46 of these, which is 65.7% of my sample. 22 of the studies looked at chronic pain, and 2 did both. They sort of looked at both aspects of pain treatment. So there was actually a fair amount of information out there on how people were using virtual reality to treat pain. Just to give you a little idea of what this scoping review looked at, as I said, we looked at both children, adults, and older adults. And I think very interestingly, we found no older adults being studied in acute pain VR. So there were no studies that looked specifically at older adults. And in chronic pain, there were no studies that looked at either children or older adults in the use of VR for chronic pain. So we have some big gaps in the research just on whether VR is a useful tool for children and older adults. Things like females were pretty much balanced, but you can see that the sample sizes tended to be pretty small. So we're still doing a lot of early work in trying to understand how virtual reality might work. We basically found that diagnosis divided up into 2 types. We had diagnoses such as musculoskeletal pain, neuropathic pain, and cancer. But a lot of studies looked at what I called procedures that caused pain, like dental procedures or puncture procedures or burn or wound care procedures that cause acute pain at the time of the procedure. And a VR headset to reduce that acute pain during the time of the procedure was something that people like to use. And you can see again in our outcomes that acute pain, a lot of them looked at procedures, but not diagnoses. And in chronic pain, none of them looked at procedures, they only looked at diagnoses. So you can see there's a lot of variation in how people are looking at virtual reality in the treatment of pain. And while a lot of information came out of this, what I thought was most interesting was looking at how many articles found significant results. Now I know significance is a slightly weak way of looking at results in a scoping review. It's a yes, no, yes, it was significant, no, it was not significant. But if you look at these results, of these 70 articles, almost 70 of them, it's about 66, had significant results where the virtual reality affected pain. Primarily, pain intensity was measured, but we also looked at the quality of the pain, whether people were thinking about the pain, whether there was a proxy reduction in pain, and then there were some other ways that people measured pain. There were only about 20 studies overall that had non-significant results, and there were a few studies that had inconclusive results. So you can see that in VR and its effect on pain, there are a lot of significant effects that happen to people when they put the VR helmet on. So this makes it a very intriguing treatment for chronic pain or pain in general. I've also started doing some preliminary work in my lab on virtual reality and pain. And as Fox had mentioned, I've only been doing this for a fairly short period of time. I really only discovered virtual reality as a pain treatment method about 6 years ago. And with COVID in the middle, it hasn't given me a whole lot of time to really get going in this area. But what I found has been very interesting. With Megan, I did a study looking at introducing VR in the pain clinic where people received 3 10-minute sessions of virtual reality during their rehab process. We found that pre and post to this treatment, they had decreases in pain, of 1.2 and 1.7 Cohen's d. So very large effects on pain for these individuals. And at least 75% of the subjects had a decrease of pain of greater than 2 on a numerical reporting scale. We also did a single arm study on older adults with knee OA, where we tracked them for 1 session and did meditation enhanced by virtual reality. And again, we saw this really large effect of virtual reality on pain. We also found that the pain reduction remained after the session was done for about 24 hours with an effect size of 0.58, which was significant from their pre-intervention pain report. And that 63 reported greater than 30% change in pain during the session. Currently, I've been working on a crossover design of people with chronic back pain, where I was looking at dosage, whether a 10-minute session or a 20-minute session was more effective. And I'm looking at using what I call diverting virtual reality programs. And I'll talk a little bit more about that a little bit later. And we found in general that 20 minutes had a larger effect than 10 minutes, but they were not significantly different from each other. And there seemed to be a strong order effect. So it suggests that potentially it doesn't matter if you do 10 or 20 minutes of virtual reality, or it may matter where you do it in your treatment, how it's going to affect pain. And again, I'll talk a little bit more about this later. So why do we consider virtual reality as a potential treatment for pain? It has a lot of benefits that other therapeutic mediums don't have. For one thing, it is highly relaxing to individuals. You can do virtual reality that can cause a great deal of relaxation for people with chronic pain. It's an opportunity for people with pain to escape what's causing the pain, to escape their regular life, to not be involved in their pain and be doing something really interesting and fun in a way that they haven't been able to do if it's chronic pain in a very long time. Virtual reality is highly distracting. When people are in there, they lose track of time. They go into flow. They start to really inhabit whatever universe they put them in. This is a universe that they don't normally get to be a part of, and this distraction is extremely useful for them. It's also fun. And I'll say, how many treatments for chronic pain are fun, where people actually say, I want to do this because I'm enjoying myself when I'm in here. And they get a reduction in pain and they leave feeling better about themselves. I also think it's really important to note that virtual reality is basically an intervention that is non-stigmatizing, namely normal people do it for fun, and it doesn't really focus on the patient. It focuses on them as a participant in this virtual world, and allows them to be people instead of patients when they are being part of this, this intervention. And it's non-invasive, and it's non-medication. All things that can be very important when you're trying to treat individuals. They don't want to have shots, and they don't want to have to take additional medication. So there are a lot of potential benefits for virtual reality that I think make it an ideal therapeutic medium for treating certain types of pain. So I want to talk a little bit about what virtual reality is, because as I say, a lot of people have very little experience with them. They don't really understand what it means to use virtual reality. So essentially, when we talk about immersive virtual reality, it is a three-dimensional, life-size, computer-generated environment that the individual interacts with via a headset and often a set of controllers. And the person in that environment feels like they are fully immersed in that environment, that this is their world at that moment, particularly if it's a well done virtual reality program. So whatever happens to them in there feels real, and it feels like it's happening to them in that moment at that time. And I want to talk just briefly about the virtual reality continuum, because it's not an all or nothing mix. As we become more proficient at the hardware and the software related to the virtual reality continuum, we can have anywhere along this continuum when we are doing treatments. So if you think of virtual reality as being continuum, on one end is the real environment. The real environment is basically where we are right now. On the other end is the virtual environment, which is essentially an environment that is entirely projected, entirely created. And you have to wear a headset to block out the real environment so that you are completely immersed in that world. Then along that continuum is the idea of augmented reality, where there are virtual things that are projected on a real environment. And the Wii is probably a good example of this. And then there's augmented virtuality, in which the environment is primarily virtual, but you can add certain aspects of the real world into the virtual environment. So for instance, if you were doing therapy with somebody, maybe the therapist is real and the rest of the environment is virtual. So they're all different methods along this reality continuum. I am going to be talking just about the virtual environment, the virtual reality continuum, rather than anywhere along it. So we are in a fully immersed environment when I'm talking about these outcomes. Now, I wanted to give you a general idea of how real virtual reality can seem, even if it is a programmed game of sorts. So I'm going to run a program that is one of the available games in virtual reality called The Climb. And I want you to, as you watch it, imagine that you are seeing this in 3 dimensions, that there is no other environment but this, and that you feel like you are in this particular area. So let's see if this will work. Uh-oh. Okay, it's not running for me. I apologize. Give me half a moment and I will find it.
Nancy, if you reshare and share the to the bottom left, there's the option to share the sound.
Okay, it just wasn't running. That's the problem. It's not a sound issue. It's just not running. So give me a second. My apologies. I thought it would run earlier when I tried to run it, but of course, this is not what happens when you actually. Okay. All right, give me a second to reshare. Oh no, it's gone. All right. Let's see if this will work. And hearing it?
Yeah.
Thank you. see in this particular VR experience, it is extremely realistic. And you honestly feel like you are in that particular area, looking at climbing that mountain. I have a fear of heights, and I find, I have a fear of heights, and I find when I watch that, it always gets my adrenaline up because it always makes me very nervous, even when I'm not in the three-dimensional area. So, all right. So I've got the video back. Hopefully everybody can see this. So what I want to do now is I want to talk a little bit about some of the proposed mechanisms for how virtual reality affects pain. And these are only proposed. There's still a lot of work being done trying to understand why VR is effective. So this is some of the ideas that people have. And in my scoping review, we found there were essentially 3 types of mechanisms that seem to come through again and again. The first and most common was distraction. So approximately 72% of all the studies use distraction as their mechanism for reducing pain. The other 2 types of mechanisms are embodiment and enhancing an existing treatment. And you can see for the acute type of pain, embodiment was never used, but it was used quite a bit from more than half of the studies in our chronic pain group. So I'm going to talk about each one of these so you have a little better understanding of what we mean by distraction, embodiment, and enhancing existing treatment. So distraction, as I said, is the most common reason that people use virtual reality. And the belief is that it works is because it engages resources which otherwise would have been used to attend to the pain to be in this virtual reality environment. And because the virtual reality environment is so engaging and so enhanced, people just forget that they're in pain. Also, part of the reason it's easy to distract people in pain in a virtual reality environment is because you have no body. When you are in a virtual reality environment, you just have whatever pictures in front of you, and there is no reminder of your body or what you are doing with your body. What they have found in some studies is that in virtual reality, attention is an important part of why distraction works. And they found that there's an increased activity in cortical areas for attentional processes and pain modulation, and a decreased activity in areas for pain perception when people are in the virtual reality world. So we're enhancing pain processes and modulation, and we're reducing how people perceive pain. Additionally, emotion is a very common cause of pain, or something that can facilitate or increase pain. And in VR, you can easily change people's emotions. You can make them feel happy, make them feel sad, make them feel excited by the very nature of whatever program you use. And this also can manipulate and change people's perceptions of pain. The second thing I want to talk about is embodiment. And embodiment's a little bit more complex and a little more interesting than distraction, and actually not very intuitive. I think it's the most interesting part of VR, and I'm hoping to do some more work in this area to start to really explore how this might be used for people with pain. So embodiment is a subjective experience, and in it, people view this simulated body that you create for them in this virtual world and whatever is happening to that simulated body, but they process that as if it were their own body that was being affected. So they see what's happening to this virtual body, and they react as if it's happening to their own self. And people have hypothesized that a sense of embodiment requires basically 3 important things. The first is a sense of self-location, and that is that you feel that the simulated body is in the space where it should be, where you yourself as a person feel like you're located. So a virtual or simulated limb is not going to work very well if it's way away from the body, but if it's very near where the arm or the body is supposed to be, there's a good sense of self-location. A sense of agency refers to this ability or feeling that you can control the body part within the system, that the simulated thing is being controlled by you, that when you move it, it acts the way you would predict it, and that there are actual consequences when you move that body part or when you're using that body part. The final sense is the sense of ownership, and that is that this feeling that you attribute and possess and own this simulated body part, and that it is part of your body. So if you can create this sense, these senses in VR, you can create a sense of embodiment. And when people have a sense of embodiment, they then perceive whatever is happening to the simulated body or simulated body part as being part of their own body. So what I want to do is I want to show you something called the rubber hand illusion, which really is a useful way of understanding how embodiment works and what it looks like. Let's try this.
I have an experiment that we're going to do today. Is I'm going to train your brain to believe that this hand, this arm, is your arm. You see we've got this divider here? So right now you can kind of see your arm. You see the arm there? And I'm going to cover over part of your arm. Now I'm doing that because your eyes talk to your brain. And your eyes tell you this is what's happening. So now, can you physically see your arm, your right arm here?
No.
Great. So I'm going to take these two classroom rulers. So we're going to train the sensations. You feel the rulers touching your hands because it's now becoming one with your mind. That this right hand is your right hand, right? You are believing that as I drag the ruler on your right hand there,
it totally
that it is
feels.
in fact in your brain, your
yeah.
right hand.
It totally feels like my hand. That's crazy.
Feel the sensations line up with each finger.
What? Whoa, yo, this is crazy.
Yeah. So now if I just do like a little tap, right?
Yeah.
Feel the knuckles. Feel each digit.
Oh, that's
Okay, this is where.
that's crazy.
Yeah. Now I'm gonna do this one more time to train your brain.
Okay.
Right. So you feel your thumb.
Okay, yeah.
And your index finger, middle finger,
This is nuts.
your ring finger,
Oh my goodness.
and your pinky finger. And now you're gonna feel it when I tap it. You feel that?
Yeah.
And that. And
Whoa.
I'm gonna let you in on a little secret.
Yeah.
I have not been using the other ruler.
What?
You feel that?
Yeah.
I am not using the ruler.
Whoa. What do you... I mean, that's crazy. It's not... Oh! Whoa,
You
and
felt
even
that,
like...
right?
Oh, no.
Now, check
Oh.
this out. We're gonna do a little test now.
Watch the
Again,
other
this is
hand.
all
His actual hand is
retraining your brain
hand.
to feel sensations.
Okay.
But your brain is thinking that it's feeling it.
Okay.
So even if it gets a little, what would be considered painful, I will not be harming you because of course I'm not going to be actually hitting your right arm. But your brain really believes that this is in fact your right hand.
Oh,
right?
this is making me nervous.
All right, here
Okay.
we go. I'll start lightly. Feel that on the thumb.
Whoa, yeah.
Your finger's moving when you tap it.
Whoa.
Ring finger.
I'm totally feeling it in this hand. It feels...
Pinky.
It just... Oh. Wow, this is so
Back
strange.
of the hand. Do you feel that?
Yeah. I want to move my hand, but it feels like I can't.
All right. So you can see this is what embodiment looks like. He was that rubber hand was embodied to him. He was, even though he knew it was fake, he knew it was not his real hand. His brain told him it was, and his brain sent sensory information when it was being touched up to his, so that he perceived that things were being touched. So this embodiment then allows us to have the ability to manipulate simulated body parts in ways that we cannot manipulate real body parts. And we can manipulate simulated limbs or painful limbs in ways that we cannot manipulate actual limbs. things that we can do in virtual reality, for instance, might be changing the color of the limb or the transparency or the movement. And there's some indication that changing these can reduce or increase pain in individuals. Most of this stuff has been done in the lab. So it's not as clear what will happen when it's not induced pain, when it's actual pain that people have from a period of time. But there is evidence from what we call guided motor imagery, which uses embodiment using a mirror to embody the affected limb by placing a mirror between the affected limb and the unaffected limb and having the individual watch the hand in the mirror move. And you can embody that hand in the mirror to be seen by the individual as their actual affected hand. And it's can be very effective after several treatments of these. You can sometimes see a pretty decent reduction in pain and more use of that limb using this guided motor imagery. So embodiment is a very interesting aspect, and Augusta will be talking a little bit more about it when she talks about when she does her talk. So one example of this I just wanted to talk about was an article by Rizzo that looked at embodying limbs to reduce phantom limb pain. And they were very interested in looking to see if they could, what would happen if they embodied a limb onto somebody with a lower extremity amputation, particularly when they had phantom limb pain. And what they found, what they did was they created this virtual environment. And in that virtual environment, the person saw their both legs existing, including the amputated one, and periodically a wave would come up and wash over the feet of the legs. So that was the visual tactile aspect of this program, kind of like the ruler that you saw in the rubber hand illusion, which helps strengthen this feeling of embodiment. And after they had run people through what they called synchronous, where the wave and the visual feeling of visual tactile was the same, and asynchronous, when the wave and the visual tactile was not together, was asynchronous. They checked on the embodiment, and they found that people were quite highly embodied when the synchronous wave action happened. But even more interestingly, the individuals in this study, the person labeled H, felt like his limb was really short. And after the virtual reality, it felt like the limb was the normal size again. The person with the limb I felt like his leg was canted or displaced to one side. After the virtual reality, it felt like the leg was in the normal position. Having a perception or this feeling that your leg is too short or canted to one side is likely to be uncomfortable and painful. So if we're able to replace the limb and in such a way that people feel like their limb is normal again, this holds good possibilities for working on phantom limb pain. The other type of mechanism that we've seen in the literature is enhancing existing treatment for pain. So using virtual reality to deliver what is already known to be a somewhat effective pain-reducing therapy, and that this may enhance the treatment. So there are a couple of studies that have looked at this, and I just want to hit two or three of them. One is that people have been using this now to start providing training, so skill building, such as mindfulness or relaxation, using virtual reality as a medium to provide the skills. So one study by Darnell did just this. They provided skill training either using virtual reality or using audio of these same skills. So exactly the same skill building, but it was either virtual reality or auditory. They had 97 people with chronic pain or fibromyalgia. And after 21 weeks, you can see by these diagrams that for the people in the VR, they had a significant and greater reduction in pain intensity by almost a point. And for the people, again with the VR, they had a significant reduction in pain-related activity interference or pain interference compared to those who just received the audio information. So it seemed like the VR enhanced what they felt was already going to be a useful information, because you can see, at least for the pain intensity, both groups did improve over time, but the VR improved more. The other place that virtual reality could potentially be used is in exercise. Now, exercise has been shown again and again to be a really useful way to reduce pain, but a lot of people with chronic pain in particular don't feel confident exercising. Well, in virtual reality, you can often get people to exercise more more intensely. And in this one study done by Stewart, they had them playing 3 different games, and in the virtual reality, they had much higher actual exertion than when their perceived exertion. So they would basically ask on the Bohr scale, what do you perceive your exertion during that game was? And it was much lower than their actual physiological response to the game. So here's an opportunity to have people work harder and not even realize it. So again, there's a way to enhance treatment. Finally, in our own study looking at knee osteoarthritis, we enhanced meditation by having people meditate in the virtual reality environment, where people could actually believe they were sitting by the seashore doing their meditation rather than having to envision or imagine it. So people were able to learn how to do it, I think, relatively quickly. And again, we saw that large reduction in pain during the VR session, a continued reduction in pain post the VR session, and then 24 hours later, we still saw a significant reduction in overall, in knee pain and in overall pain past the time when they were actually in the virtual reality. So there's some suggestion here that there may be a carryover of the effect of virtual reality past the time that they're in, suggesting it's more than just distraction. Something else, maybe embodiment, is going on. So the last thing I want to talk about briefly is how you can integrate VR in the clinic. Because a lot of times when I talk about this with clinicians, they're like, yes, this sounds really interesting, but is it feasible and possible to use it in the clinic? And Megan will be talking a little bit more about how she's been using it, but I want to just go over some of the thoughts that we've had as we've started to look at using VR in the clinic. The first thing you have to consider when you're putting together a virtual reality program is the system that you're going to use. And there are a lot of systems out there, some of them very inexpensive, some of them not very inexpensive, but not inexpensive. That didn't come off right. Anyways, there are some very good systems out there that are not that expensive. Most commonly, we see the Oculus and the Vive systems. Both of these provide excellent VR experiences. And the current price of a headset runs at about $300, $400. So not outrageously expensive. When you are considering a VR system and what you want to pay for, you have to consider things like immersion and presence. So immersion is the idea of how much that you are actually feel like you are in this reality, and this reality is the reality that you're in and that it actually exists, and how much you can ignore that outside world. And presence is how much that reality reacts like a normal world. So if you are in a world and people are floating, you better be in a space station and not on the real world. So it's how well the VR system can do both these things, immerse somebody and give them a sense of presence. You also have to think about tethered versus untethered headsets. So a lot of the virtual reality headsets connect to a computer. And when they connect to a computer, they connect via a cord. So that would be a tethered experience. And the problem with that is that it limits movement a little bit. People get tangled in the cord. If they turn around, they may wrap it around themselves. So untethered allows you to work in a VR system that is not connected to a computer. And very recently, within the last year or so, Oculus has come out with a very excellent untethered system that has almost the same quality of movement as a tethered system. So there are some really good untethered systems out there. You also need to understand what VR experiences are available through the headset or through the system you're going to use. Each system tends to have its own experiences that have been designed. So you need to understand what there is available and how usable the headset is and the controllers are if you use hand controls for an individual in that headset. There are also different types of VR experiences, which I've divided into passive and interactive. Passive experiences are essentially like watching a movie, but a three-dimensional movie. And if you go on YouTube, you can see people have developed what they call 360-degree videos. And these are videos that basically surround individuals all the way around top and bottom. And you can sit and watch these and feel like you are in this space, swimming with dolphins, walking through a rainforest. But you cannot have any effect on the environment. It is all passive. You are just sitting and watching. And you can do this in a headset without any controllers. The interactive, on the other hand, are more what I think people think VR is like. These are experiences where you can interact with the environment, you can make changes, you can wander and touch animals, you can play games, you can go on quests, you can complete puzzles. There are all sorts of different things that you can do in an interactive experience. The complexity becomes how you get to use the controller and how easy it is to understand how this experience works. So you have to sort of make a decision on what you want people to be doing. I mentioned that I was looking at dosage in one of my studies. That's because when we did our scoping review, we found that there was no consistency in dosage at all, that we had studies that ranged from 1 minute to 31 or plus minutes, and some were the full length of a procedure. So if someone was in labor, they might wear the VR system for the entire labor experience. So there really was no indication what was effective or necessary particularly for chronic pain in the VR space. And as I say, I've been working on a study, and at this point, looking at 10 versus 20 minutes, which seems to be the most common that people recommended. At this point, while 20 minutes seem potentially better, there's such a large order effect, and there's no significant difference between 10 and 20 minutes, even though 20 minutes had a larger effect overall. It suggests that it doesn't, at this point, it doesn't seem like it matters whether you put someone in for 10 or 20 minutes, as long as the experience is an experience that is immersive, they have presence, and is doing the tasks that you want to do. I would be remiss if I didn't mention that there are adverse events associated with VR. One of the biggest challenges in VR is that you have to occlude the vision. I mentioned this before. It's an advantage because now you get rid of the body. But if the vision is occluded, that means there's an increased risk of tripping and falling. If people have balance issues, they're more likely to not be able to stand while they're doing the task. And there are VR experiences that can be done seated. So vision occluded, and you could walk into walls, you can walk into chairs. There are a bunch of things that could potentially happen. The VR headset is designed to minimize these. When you set people up in it, you clear the area, and the headset itself sets up a virtual fence that lets people know when they're walking out of the gaming area so they don't start walking into walls. But it's still something you need to be aware of when you're working with individuals in VR. Another issue that can come up is motion sickness. Because the vestibular system is saying you're still and the visual system is saying you're moving, this can cause people to feel like they experience motion sickness, or they call it simulator sickness, with all the things that you might expect in motion sickness. Upset stomach, headaches, visual problems, focus issues. So some people can't get into the system. One thing we have found is that for people who have mild motion sickness, if you do it a few times, they tend to adapt. So the first time they may experience some motion sickness, but it gets better with time. The final thing that we have been aware of, but have never seen, is the possibility of infection. Because the headset is right on the face, touching the skin, there is a possibility that you could pass infections from one person to another if you use a headset in the clinic. So we use silicone masks over the VR headset right along in here that we can take off and clean. We wipe the equipment down, and so far we have not had any reported infections from any of our lab or any of our clinical visits. So it's something to be aware of, but not something that we yet have seen. And the question always becomes, is it feasible? I mean, how long does it take to get individuals into this system, run it, and get them out? As I said earlier, Megan and I did a study where she was looking at individuals going into the headset during part of her treatment. And she basically had 29 patients that she followed, and she brought them in, and she was able to do 10 minutes of VR and followed up with regular therapy with no problem. She saw a large change in pain in these individuals that was significant pre and post the intervention. And you can see we have a change score of 3 points on a numerical rating score, which is large. And a minimally clinical, that 75 or 85 or 90% of people met the minimally clinical important difference of greater than 2 on that scale. So you can see that there is this real potential to be able to use this in the clinic as part of any sort of regular therapy. So to summarize briefly, we have seen that virtual reality can have this clinically important effect on pain. We've seen 30% change in pain in some situations and a greater than 1 point reduction on a numerical rating scale, which are all important aspects of addressing pain. We see that there are several mechanisms that potentially could be addressing pain. So it's not just coming potentially from one area. It is coming from multiple areas, and that things like distraction and embodiment can be used to manipulate the pain reaction, and that we can use it to enhance other more useful, or not more useful, but enhance other useful and effective mechanisms. And that it is feasible, that you can be used as part of a comprehensive pain program. It is not something that requires a lot of additional work once you understand how to use it and how to get it in there. So I'm hoping that after having watched this, you'll be at least interested in learning more about virtual reality and how it might be used. But I have to point out that virtual reality for pain is still really in its infancy. We still have a great deal to learn about how it works, why it works, and who it works with. But I'm hoping that in the next 10 years, now that we have very accessible virtual reality headsets, and we have lots more people who are interested in this, we're going to start to be able to see how we can use this to effectively treat pain. So thank you for your attention, and I'm acknowledging people who have worked with me in the virtual reality clinic, 2 of whom you're going to have a chance to hear from. And I have references if anybody's interested. Now, I assume, Foxon, that we're going to hold on questions and have Augusta and Megan talk, or do you want me to take questions now?
Yeah, we can get some questions now, Nancy.
Okay.
Yeah, it's really wonderful and exciting. So any questions, please feel free to unmute and just ask, or you can write in the chat as well. So Nancy, what about neuropathic pain? You talked about acute and chronic pain. It's really, how does
there is some evidence. They've been using it for neuropathic pain, particularly for individuals with like spinal cord injury, with some success, that they have been able to reduce neuropathic pain in these individuals using virtual reality. It seems to work on the embodiment route. And I think, Augusta, you're going to be talking a little bit about a study that looked at neuropathic pain with embodiment in just a couple of minutes. So it does seem to be a potentially, and again, I'm going to say potentially in front of everything, even if I don't forget to say it, because there's still a lot to understand, because most of the study in VR that's been done has been done on either typicals, so they embody on typicals and they don't look at pain, or it's been done on induced pain in the lab. So they make people feel pain and then see what happens when they put them in the virtual reality. So we don't have a huge amount of information yet on chronic pain in particular. Acute pain, yes. Chronic pain, not as much.
Okay. I think we have got a question from Mashid in the chat. Says, thank you for this interesting.
We have a VR specific pain distraction score. We don't have a VR specific pain distraction score at this point. It is, a lot of it is based on individual preferences, and that is definitely something we found in our study. Although most of the people that wound up, have come into our studies have never had VR before. What tends to happen is they're very excited in the first visit and it's all new and interesting. But if the VR experience is not sufficiently interesting, they can get bored pretty quickly. So I think your question is really important, because it's one of the things we have to figure out is, what's the just right distraction for somebody that allows them to not pay attention to the pain, but still isn't so complicated that they can't do it? Because some of the VR things are very complicated. If you've ever played some of the, Quest video games that go on for 5 or 6 hours or 7 hours, you can't put somebody in that because they just don't have the time to do it. And you want something that's sufficiently interesting from the very beginning. So I hope that answered your question. I'm happy to speak more on that if you have further questions on that.
Yeah. I think the one obvious question is, how long does it take? I think you talked about 24 hours pain reduction remained after session.
We have seen that. That was a single session. Megan may be able to speak more on several sessions because she's been doing it in the clinic. So she may have able to talk about that. We think there is going to be carryover. That's one of the areas that's been, I think, insufficiently studied to really be able to talk in any certainty. But it seems like, yes, it seems like for some people there is a carryover of the VR after they've gotten out of the VR. Megan?
Yeah, I would probably say that in terms of carryover, we're kind of looking into like reduction in fear of movement. And so we're kind of unsure of the mechanism of why they have less pain. If it actually plays into other mechanisms versus just the pain itself.
Okay. Yeah, I think we can move to.
If you don't mind, I just have sorry. Yeah, wonderful work, actually. Very, very interesting as well. I had some questions on the immersion. So does everybody get equally immersed in the VR experience? And does this, how deeply they're immersed, does that really affect their pain response or the response to it? So like for instance, could that account for some of the variability that you're seeing? Yes. And second, is it possible, or I've heard at least that the VR experience could activate the opioid system? Does that play any role in the pain response?
Yes, immersion is important. We definitely have found that if people do not feel like they're immersed in the environment that is not real, it's going to be less distracting and less interesting. So part of the challenge is trying to find the best program that immerses, and it's going to be different for different people. I mean, part of the VR is that emotional reaction to where you are. And if you love the seaside and hate the mountains and you're in the mountains for your VR, that could definitely affect how immersed you are, how comfortable you feel with it. What does happen sometimes is people are actually triggered in the VR. We've had, I think, Megan, you were describing somebody had an aversion to birds, and some birds flew over in one of the VR experiences, and it triggered them. It was so real to them that these birds were there. You know, I had somebody, we have an ocean one, and there's seagrass, and the person I was with like, oh, I don't like seagrass. I don't want to be here. I'm like, okay, this is fine. I don't know about the opioid reaction. I don't know if it follows the same pathways. I think it would be interesting. That's one of those areas I think we want to look at what's happening in the brain and look at more clearly what is happening when we put somebody in a VR environment. As I say, we have lots of proposed mechanisms, but we're still doing a lot of work to try and figure out what's going on. Why is this working? I mean, the distraction seems pretty obvious. I mean, everybody, when you have pain, you distract in some way, often distract in some way, shape, or form, and VR just seems to be a really efficient way. But it seems like it's more than that. So, you know, trying to figure out what that is and enhance that, whatever that is in the VR, I think could be really, really potent in pain reduction.
Thanks.
All right.
Yeah, that's excellent. So maybe we could hear from Professor Polhemus and.
Yes, I can go now, Megan, if that makes sense for the flow, because I'm going to be speaking about what we found in the research, and then Megan can continue on with what she's doing in her clinic. Okay. So let me just hopefully get this. Can everybody see that?
Yes.
Okay, great. All right. Almost there. Okay. So Dr. Baker just, as we saw, touched on and started to discuss this concept of embodiment. So we wanted to take you just a little bit further into how embodiment is coming up in the research, things that we're looking at in our lab, and then deeper what we found in the literature. So to start, I wanted to begin by just starting to talk a little bit about this concept of embodiment and how it happens in the brain. So the question of how does the brain represent our body? This is a question coming up in cognitive neuroscience a lot right now that we've seen within the literature. So the body schema is controlled by a distributed neural network. This neural network is mostly genetically pre-wired and also flexible at the same time and open to the continuous shaping and influence of life experience. So we generally believe that our own internal body representation is stable. However, there have even been some studies done where the illusion of body ownership over an object happens, where the object is not part of the body at all, which suggests that our body and our body's representation is actually highly malleable. So this neural network is comprised of the somatosensory system, reticular afferents to the limbic system, cortical regions that are important for self-regulation and recognition of external objects and entities, and especially here looking at the somatosensory inputs. So these inputs from the brain from different modalities, such as visual system, tactile, proprioception, and the execution of movements are extremely essential for bodily awareness. Tying this into what we saw with Nancy is looking at the brain's ability and the brain's perceptual system resolving the sensory conflict between the proprioceptive input of the indication of the position of the real hand that we saw in the rubber hand illusion, combined with the visual tactile information of the visual position of the rubber hand, together with the tactile stimulus from the stroking, causes what basically creates in our brain an override. Our brain overrides the contradicting proprioceptive input and actually produces the incorrect position that the real hand is actually located closer to where the rubber hand actually is. And this is called proprioceptive drift. Something that's interesting as well here is that studies have been done that look at this experiment with an asynchronous visual tactile stimulation, and the illusion has not occurred. I say this because other studies have been done where there is no tactile element and embodiment occurs. So really what I'm getting at here is there is so much potential and so much possibility for where embodiment can go. We really wanted in our lab to dig deeper into what is currently being done in research, specifically with virtual reality, embodiment, and pain. And I say that because we have seen really incredible work being done with embodiment and other types of outcomes and other diagnoses that aren't connected directly with pain. For example, there's a fascinating study looking at schizophrenia patients embodying their auditory hallucinations. So in our lab specifically, as noted, we're looking at embodiment, virtual reality, and pain. So we really wanted to focus on experimental studies with specific diagnoses. As Nancy mentioned, there are many studies that are being conducted with healthy controls. And in order to start to understand what best to do in our lab next, we really wanted to look at, again, these specific diagnoses. So we allowed healthy controls in our search, but not as the primary population. We looked only at adults and only English language. So we're in the early stages of analyzing what we found, but we initially found 180 articles, and through the systematic review process, we've ended up with 10 articles that we took data from. And overall, generally what we saw, and again, we're in the early stages of analyzing this data that we extracted, but the sample sizes were pretty small. It was mostly mid to older adults, so late 40s to 60s, both male and female. Primary diagnoses we saw were chronic regional pain syndrome and general chronic pain. We saw a few others pop up, and the primary the primary outcome that we saw was pain, but that was also because that was one of our major criteria for our scoping review. I wanted to pull a couple of examples for you to, again, illuminate what's going on within research with embodiment, virtual reality, and pain. So the first study that I've pulled for you is a study that designed and tested a new procedure by combining spinal cord stimulation, SCS, and immersive virtual reality to enable analgesia in patients with chronic leg pain. So the hypothesis of this study was that a virtual representation of SCS-induced paresthesia would boost SCS-induced analgesia. 15 patients with severe chronic pain and an SCS implant were part of the study. At baseline, the experimenter had the patient observe their virtual body in the headset, and then they produced a visual illumination on the virtual leg that was defined by manipulating visual parameters such as color, intensity, the size of the pattern, and the frequency of the illumination until it best matched the patient's subjective feeling that they were receiving from the SCS. Within this study, there were 3 conditions. The first condition was virtual reality alone, seen all the way on the left. The center image was congruent SCS and VR, where visual feedback was provided on the patient's leg, as seen from the first person's perspective. And again, that tactile sensation that was elicited by the SCS stimulation corresponded to the illuminated area that was created at baseline. And then the image farthest on the right was incongruent SCS. So this speaks to what Dr. Baker spoke about earlier with self-location. In this other control that they used, they rotated the body 90 degrees so that there was a misalignment spatially between visual feedback and the SCS-induced paresthesia. They tested the immediate effects of pain several times during the VR exposure, and they also had the patient turn off the SCS, and then 10 minutes after, they looked at if there was a carryover effect. So what did they find? They demonstrated in the study that the spinal cord simulation VR, the SCS VR, was stronger than that in both control conditions. The SCS VR analgesia kept increasing over successive stimulations, which revealed a selectivity and consistency of the observed effects. And also at the 10-minute mark, after the participant had turned off the SCS and the VR had stopped, they did see that there were initial carryover effects that indicated some therapeutic potential. The second study we wanted to show here today for you investigated whether varying properties of a virtual arm co-located with the real arm modulated pain ratings in patients with chronic arm and hand pain because of chronic regional pain syndrome type 1 without nerve injury or peripheral nerve injury. So in this study, there were actually 7 conditions under 2 umbrella modalities. So there was a transparency test that looked at 0% medium opacity, high opacity, intermediate opacity, and 75% transparency, low opacity. There was also a size test that varied the length of the arm. So there was the doubled arm, which was the big arm, so double the length, a normal length arm, and then a sized arm that was half the length. There was an additional element in this study as well of a visual tactile stimulation where the participant was cued in the headset to pay attention to the arm located next to the book before each stimulus was presented. So virtual balls tapped the finger based off of vibration attached to the fingertips of the participant. So this study also found that increasing transparency levels of the observed visual arm decreased pain ratings in chronic regional pain syndrome, but this did not occur in the peripheral nerve injury patients. Size increase also increased pain ratings only in the chronic regional pain syndrome patients. This is interesting to note because the specific underlying mechanism of each type of pain likely has a role in the type of strategy that is more effective for reducing pain in pain perception in clinical patients. So the author also noted that overall, the conditions globally decreased the mean pain ratings by half by the end of the experiment. So here we come again to the possibilities and the potential. As we've seen, there is a lot happening with virtual reality and chronic pain, and it seems to be working. It seems to be applicable, but the seams and possibility and the potential is what is really, I think, at the foreground right now. And we need to look more into what mechanisms, what modalities. Is it changing the color? Is it changing the shape? Is it changing the transparency? Is it moving the body? Is it feeling touch? Is it not feeling touch? Could you potentially embody a healthy limb and not the pain, the limb that's in pain? And does that influence what diagnosis we're looking at? What diagnosis is going to be the most, influenced by being in virtual reality and embodiment? What is the dosage and duration? And then ultimately as well, how do we measure embodiment? How do we know that someone's been embodied? It's a lot of outcome measures that people are creating themselves to try and figure out people's responses. So there's so much that we can do with embodiment, with pain and virtual reality. And it's really exciting to be part of this process in the lab. So thank you for your time.
Thank you very much. I think we're going to move to Dr. Kenney.
Okay, we'll share my screen. All right, can you guys see that? Okay, great.
Yes.
Okay, so I'm going to talk a little bit about virtual reality and clinical implementation. So as Nancy mentioned, we've been working in virtual reality and occupational therapy in the clinic for about 6 years. We've tried multiple formats and we've learned a lot over the years. So a little bit that we know about chronic pain in general in the outpatient setting for occupational therapy is that multimodal care is really the gold standard. So more is better is essentially what that means. So, a lot of our patients, they have nerve blocks, injections, medications. They see the physician often, and they also come to therapy. And so in coming to therapy, sometimes they receive standard care, which I'm going to go over a little bit about what that means. Standard care for outpatient occupational therapy for chronic pain. But we wanted to look at what that means to add virtual reality as an intervention. So Nancy mentioned that that's one approach, is to add VR to what we already do to see if more is better. So kind of that multimodal approach. So what we did in the study that we're currently doing is we chose to add VR with a debriefing component. So essentially reflective learning, talking with the patient after they do the virtual reality about their experience, to standard care in our outpatient occupational therapy setting. And we compared those outcomes to just standard care alone. And we wanted to see if our VR plus debriefing plus standard care was better in terms of reducing pain, improving functioning, and meeting functional goals, reducing fear of movement, and improving self-efficacy. So these are all things that are really important to us in the chronic pain therapy world, because we know that reducing pain alone is not enough. So I need my patient to go out into the world and believe that they can do things well, and believe that they don't have to fear that they're going to re-injure themselves. So this is a very important concept. So just to touch on what is standard care. So some things that are important to know is that in chronic pain occupational therapy, so what I typically would provide to my patient is a lot of education. So things like pacing. So teaching them how to not overdo, but I don't want them sitting in bed all day either. So I'm teaching them what's that happy medium in terms of activity level. Things like body mechanics. So how to move in a way that's safe and stops them from re-injuring themselves or increasing their symptoms. Work simplification, or doing things in a way that doesn't increase their symptoms. We always talk about working smarter, not harder. That's really how we describe work simplification. And things like ergonomics. So setting up their environment to be conducive to their body. So a really good example is somebody with back pain, setting up maybe their kitchen in a way where they can cook and not increase their back pain. And then we do things like supervised practice with feedback. So once I go through a series of educational topics, we practice in the clinic. And what does that do? that increases that self-efficacy or the patient's belief that they can also do those skills at home in a way that reduces their fear of movement. So we always go back to those same skills and kind of that technique of reducing fear of movement. And everything focuses on activities of daily living, applying techniques to daily life, versus kind of that old adage of just do exercises and you'll get stronger. That's not enough in chronic pain because we're really using that biopsychosocial model. So what we use in our clinic for this VR plus debriefing plus standard care in terms of our kind of protocol is that we did 10 minutes of virtual reality and we used a cell phone to record the participant for roughly 1 minute while they're in the VR. When they're done with the VR experience, we watch this 1 minute video with the participant. And then we go through a debriefing questionnaire with the participant. There's a questionnaire that the person fills out when they do debriefing. The front of the questionnaire has a few bubbles, kind of like word bubbles. And some of these bubbles say things like, wow, that was, and the participant fills it in. Or I did great when I, next time I would, and I'm still. And it's just a way for them to start thinking on their own before I even say a word to them. But then we also have a conversation. So I don't want to do too much of the talking. It's kind of like motivational interviewing. But I want to say, what do you think? How did that go? And I want the participant to really just let me know how they thought things went when they were in the virtual reality. Because part of what we want to do is have them connect the dots. Because remember, their vision is occluded. They're immersed. They're in the virtual world. But we want them to have carryover. We don't want it to just be fun and just be a game. We want them to actually use these skills. So we felt like this debriefing was really important. And then after we do the debriefing, we also do standard care. So maybe we do another 10 minutes of something like body mechanics education. And that's our session. So why is the debriefing so important? It closes the gap in knowledge. It allows time for the participants to really discuss what happened and participate in reflexive learning, which is a type of learning where the person explores their own experiences and becomes more conscious, open-minded, and self-aware. So you could imagine with the chronic pain population, why we felt like this is really important for them to decrease some ambivalence, to improve self-management skills, and really connect the dots. It gives them time to share about their experiences. And it connects the actions of the virtual world with the real world. And one really interesting part is the cell phone video. So when we first proposed this idea, I wasn't sure how the cell phone video would go, because sometimes when we talk about working in chronic pain, we see what we call as self-limiting behavior. So I thought, oh no, what if people see themselves moving in the VR, flailing their arms around, and then they think, well, that's why my shoulders hurt. But that's not what happened at all. It was actually the opposite, that people would get really excited to see their videos, and they would get really excited with how well they were moving in the virtual world. So what trends have we seen so far? Which I'll tell you, so far we have 10 people that have completed completely in this study. We've seen lower pain scores in the VR group post-session versus pre-session. So we take their pain scores before they do the VR and after. We haven't had a single person that didn't report lower pain after versus before. We've seen lower pain scores in the VR group over time. So we do 6 sessions with all participants, and over time, pre and post, we're seeing trends where people report lower scores. We're seeing higher VR immersion scores over time, like session 1 compared to 6. We're seeing higher goal attainment scores in the VR group versus the standard care group. So one other thing that we do is we have participants choose their own goals on visit 2 and visit 6. And so the standard care group are meeting their goals less often than the virtual reality group. And then we're seeing improvements in functional outcomes as reported through promise measures in the VR group consistently, session 6 compared to session 1. So just some interesting observations and comments that I wanted to share. Participants appeared to be motivated by watching themselves on video. So I shared a little bit of that already, but they almost seem competitive with themselves and want to put on a better performance than they did the previous session. So I've had people come in and say, oh, last time I did good, but I think I can even do better. Some of the games we play are boxing, Fruit Ninja, where they slice the fruit, or we do Beat Saber, where they kind of slice through boxes. People say things like, I want to be faster this week, or they're excited because they didn't think they could move the way that they did on their videos. Participants really have fun, and they look forward to coming back to therapy because of the VR experience. So I don't know how much experience you all have with the chronic pain population, but something that we struggle with is engagement. And people really feel hopeless often. They feel like therapy can't help them anymore. And so this is really something that I think is valuable in itself, is to motivate people to come to therapy as something novel, something fun, and something different. And also I find that education such as pacing and body mechanics appears to be helping participants use the VR more effectively without increasing their symptoms. And I find that debriefing is a pivotal moment to connect the dots. People say things like, I think I can move better in the virtual reality because of the body mechanics that we talked about. Or I move faster, but in a more controlled way because we worked on pacing and I'm listening to my body. So all the pieces of the puzzle appear to be connecting. So some of the take-homes are that participants enjoy the virtual reality. The combination of VR plus debriefing plus standard care appears to help participants understand and verbalize the use of VR, helping them become active in their real lives. Participants report less pain following the use of virtual reality, post-session compared to pre-session. And like I think you've heard from Nancy and Augusta, we have so much more to learn about the virtual reality and how it can help us with chronic pain. But I think we're all kind of excited to find out what's to come. So thank you so much.
Oh, thank you very much for really excellent talks. Any questions? Please use the chat or just ask. So one of the things that as a biologist, we think about pain. We say that, okay, pain equals nociception. Basically, we are thinking about the neurons that are residing in tissues, and then you get this tissue that is, maybe you have a noxious stimuli, and then you have the highway that is going from the cell bodies that are residing in the dorsal root ganglion, which goes through the dorsal horn and then into the brain. And then the highway comes back. So when you are talking about the mechanisms here, how does that fit? Because the first part was talking about the size, we're talking about the transparency from Professor Polhemus. So how does it fit in, or are we talking about the different potential mechanisms?
It's the thing to remember when we talk about the embodiment is that we are talking about it not so much with acute pain, but with chronic pain. And chronic pain tends to not be such a pure movement through the body. It isn't a nociceptive response. Often in people with chronic pain, there is no damage to the tissue that's causing the issue. And so we are dealing with body perceptions. A lot of times people with chronic pain have body schema issues. They don't see their body as normal. They are afraid to move, so they get sort of skewed sensations coming into their body. And I think some of the things that are happening in embodiment is, and I don't know why, again, it's really fascinating to me that transparency seems to make a difference and size seems to make a difference, and color. I mean, these are all things that is like, that seems really odd.
Right.
But, you know, perhaps by shifting the body part and maneuvering it in a way that allows someone who like feels like their arm is really swollen and now they're seeing it as being not swollen, helps them perceive the arm to be less painful. I know in the color studies, the red versus blue, I think red makes people feel more pain and blue makes people feel less pain. So there's something about cues from our environment that when we see the arm in a different way, it fools our brain, and our brain says, not, you know, there isn't as much damage going on here, there isn't as much danger going on here, therefore I feel less pain. But again, this is just sort of the initial sort of thinking about why embodiment might work the way it does.
Right. And Dr. Kenney, what is involved in the debriefing? Because you talked and emphasized about the debriefing. What's involved? What do you say?
Well, the whole point of debriefing, it's really reflexive learning. So you're kind of promoting the participant to talk more about what they think happened. So, you know, we're trying to not talk too much and tell them what happened during the VR experience, but we're trying to promote them to talk about what they think happened. So we're kind of prompting them to talk more about what they experienced.
Okay.
Yeah, it's kind of based on, we base it on education. When you do education with individuals, particularly if you do simulation education with individuals where they try something, it's very effective after that educational experience to have them debrief and to talk about what they saw, how they felt about it, what they saw happening, what they felt they did well, what they felt they didn't do well, not from your perspective, but their own perspective. And by thinking about this, you can help them to say, oh yeah, I did this really well. I didn't do this as well as I thought. And here are some things I might do differently next time. And that helps you to really learn it. And so we thought taking that educational component that we see in our classroom. So when I'm teaching people, this is something I would do, and applying it to chronic pain, where we are trying to have them learn. We're trying to have them learn new habits, new ideas, and new ways of behaving at home, that this reflexive thinking would help them to say, it's not just therapy in home, it is therapy that connects to what I'm doing at home. And here's what I did in therapy connects to what I might want to do at home, and help them to sort of, because if they don't make that connection, it's not going to work. Right. If I just tell them, not going to work.
Yeah. Any questions? Anybody?
Yeah, sure. Yeah, wonderful talks, everyone. Very amazing stuff. I just had a question again on what's more on the activities in VR. So is it important for patients or individuals to always experience something new? Like the idea of doing something new, is that kind of engaging and I guess fascinates the individual or gives them that experience, that new experience? If you do it over and over again, can complacency affect the VR outcome?
Megan can respond to that.
I'm sure there comes a time where complacency would affect the outcome, but I think what we've actually found is that people kind of like to do better than they did last time. So in terms of that debriefing model, like, what would you do better? They'll say, like, well, next time I'm going to do this. And then they really want to do that next time. So whether it's faster or the next level. So I think there's like this competitive nature or wanting to show improvement, wanting to be faster. So, that's really what we're seeing, is that the consistency is what people tend to like and respond to best. And so this is at a 6-session model, is that we're seeing that people like to do the exact same game and try to do better.
And again, it depends. I talked earlier about passive versus interactive. So this is your interactive videos. I know of places that use more of the passive type, where it's more of like a relaxation and just sort of a being, rather than, in some calm, beautiful place. And so that's sort of a different way of thinking about it. I know there are groups that use that kind of model, but we've been doing the interactive because we like our patients, our participants, to be active. We don't want them to be passive. We want them to be active in what they're doing. And movement is good for chronic pain.
Yeah, perfect.
So it'd be interesting if you included some sort of haptic device where maybe it vibrates and brings in the sense of touch.
Mm-hmm.
So you have like more senses immersed in the experience.
Yeah, that's an area that is big in the gaming world, trying to develop good haptics to make the experience more immersive. And the games that we use commercially available games. We don't use games that we've designed ourselves. Some of these have haptics, but they're pretty gross, if you will. If you hit something, it vibrates a little bit. There's no precision at this point. But I'm hopeful. The gaming community is very dedicated to making their games better and more interesting, and they're really interested in making haptics and controllers better. So I'm really hopeful that in the next 5 to 10 years, the haptics will be great, and we are reaching a point where we no longer need the hand controllers. That the virtual reality headsets won't require us to hold something. We'll actually be able to use our hands normally to do things, which will be a real plus in the therapy world.
Yeah. Thank you very much.
I guess the one issue is, will we get lost in the VR world, like all these movies that you see in Hollywood, right? Player One and so on.
Yep.
Is there going to be a point where we'll never really get out into reality? But yeah.
Yep. No, I've heard that as one of the things that I've heard people say, well, what about if they become addicted to virtual reality and spend all their time there? And when you listen to Megan, what Megan's doing is trying to really connect it to the real world and make the real world exciting. But it's like anything, some people are just going to become addicted to it. But we want to try and prevent that if we can.
Mm-hmm.
So we'd like to thank you for that really wonderful work, and really clinically relevant and cutting edge, really interesting. Thank you very much, and we wish you really wonderful vacations coming up. And yeah, we thank everyone. So this is our last seminar for this year. We'll start next year, and thank you very much, everyone, for attending all these seminars.
Thank you for inviting us. Truly, it was a pleasure to come talk.
Thank you.
Thanks for accepting.
Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Bye, everyone.